Hello, this is Varadarajulu from Orlando, Florida. It's a great pleasure to make this presentation, and I want to thank Dr. Wag for his invitation for me to speak on tips and tricks for gallbladder drainage, gastrojejunostomy, and edge procedures. So I'm going to begin with gallbladder drainage, and there are three common indications currently for this indication. One, EUS guided drainage is performed in lieu of cholecystectomy for high-risk surgical patients with acute cholecystitis. Secondly, it is used for conversion to internal drainage in patients with pre-existing percutaneous cholecystostomy tube. And finally, it can also be performed for malignant biliary decompression when ERCP and EUS have failed, although this is quite an uncommon indication. Why is EUS guided approach popular? Simply speaking, the main alternative to EUS guided drainage is percutaneous drainage, and current data proves that both techniques perform equally well from a clinical standpoint. However, EUS guided drainage likely has fewer adverse events and less need for re-interventions compared to percutaneous approach. There are two common methods by which gallbladder drainage can be undertaken. One is called the hybrid freehand approach, where a lumen-opposing metal stent is deployed over a guide wire. And the two main advantages of this technique is that when lamb's placement is being performed, you can prevent accidental damage to the contralateral wall of the gallbladder, particularly in patients when the gallbladder is not very well distended. And also, it minimizes the risk for stent misdeployment. The freehand technique is a more common approach where it is fairly straightforward and a lumen opposing metal stent is placed directly into the gallbladder, and I think a majority of practitioners adopt this approach. These two videos illustrate the hybrid freehand technique and the freehand method for gallbladder drainage. In the hybrid technique, in this particular patient who presented with obstructive jaundice, a mass was seen at the region of the cystic duct, occluding the neck of the gallbladder. It was fairly hypoechoic and straightforward. So using a biopsy needle, the mass was sampled, and on rapid on-site evaluation, this was confirmed to be adenocarcinoma. Then using a 19 gauge needle, the gallbladder was punctured, and a 0.025 inch guide wire was coiled within the lumen of the gallbladder. Being a non-contrary enhanced system, the tract was initially dilated using a ERCP cannula, followed by a 4 millimeter balloon. After retracting the balloon, a non-cautery enhanced lumen opposing metal stent was then deployed with deployment of the distal flange and then the proximal flange within the duodenal bulb. In the second video, this is the standard technique that is being currently used with the cautery enhanced system. It was a 78-year-old patient who presented with right upper quadrant pain and fever, and the patient was not a good surgical candidate and elected to undergo drainage via endoscopic techniques. So as you can see, the CT scan showed minimal changes of emphysema around the gallbladder. So using a 15 millimeter lumen opposing metal stent, the distal flange is first released after application of electrocautery, and then following that, a proximal flange is deployed within the GI lumen, and this procedure was performed without any aid of guide wire. In this particular case, we also placed a double pigtail plastic stent as the patient had several stones, and we were concerned of the patient developing acute cholecystitis due to stent dysfunction at a later time. So one of the caveats of gallbladder drainage is that one has to be careful because when the echondoscope is advanced deep into the stomach, it can push against the gallbladder and a stent can be deployed. And after the echondoscope is withdrawn, the stent can actually recoil and there can be internal migration into the GI lumen, resulting in frank perforation. And in this particular case is a nice illustration where you can see that the echondoscope is deeply bent and then the gallbladder is very further away from the GI wall and a stent is being placed. So in this particular circumstance, one has to be very, very careful about deploying a lumen-opposing metal stent from the stomach. In fact, it might be preferable to deploy it from the duodenal bulb to minimize the risk for internal migration and possibly a perforation. There are certain precautions that can be undertaken. During the procedure, it's very important to minimize contrast injection because excessive injection of contrast can result in sepsis. Secondly, some patients may not have any symptom relief at 24 hours because the lumen of the stent can be occluded by stones and debris. And in these cases, it can be overcome by placement of a plastic stent. Alternatively, if the patient does not improve very well, one should suspect gangrenous or a perforated gallbladder as a reason for lack of symptom relief. There are a couple of controversies. Nobody knows how long these stents should be left indwelling. We know that if lumen-opposing metal stents are left long-term, adverse events can happen. In one particular study, it was estimated to be 7% at a follow-up of around 9 months. And the most common adverse events were acute cholecystitis due to stent blockage and stent migration. Other adverse events include upper GI bleeding and ulceration, which have been reported between 4 to 6 months. Therefore, there are two management options that have been proposed. If a patient has got a very short survival time, then the stent can be allowed to indwell permanently. Whereas if the patient is healthy and survival is expected to be prolonged, then the stones within the gallbladder can be removed by cholecystoscopy using a standard gastroscope, and this has a success rate of more than 90%. Following that, either the lamps can be removed or the lamps can be exchanged for double pigtail plastic stent. Again, this is not a evidence-based recommendation. This is just consensus by experts. In summary, compared to other methods, EUS has the lowest chance of recurrent acute cholecystitis and highest rate for clinical success. While percutaneous methods are effective, they do have high rates of unplanned admissions and reinterventions. And transpapillary drainage via ERCP, although uncommonly practiced, is associated with high rates of adverse events. I will now move to my next lecture topic, which will be gastrojejunostomy. So EUS guided gastrojejunostomy is commonly performed for malignant indications for the diseases of the GI tract, although occasionally is also being performed for benign indications. And why is EUS guided gastrojejunostomy popular? It's popular because the outcomes are comparable to an enteral stenting, and some experts have suggested that the rate of adverse events may be lower. And additionally, the rate of symptom recurrence appears to be significantly less for EUS guided gastrojejunostomy than conventional enteral stenting because there is frequent tumor overgrowth into the stent, or there is and stent-related dysfunction, whereas with EUS-GJ, this limitation can be overcome. There are multiple ways how a EUS-guided gastrojejunostomy can be performed. Although 6 techniques have been described, the 2 most common techniques are, one is called the direct method, where a lumen-opposing metal stent is deployed directly into the fluid-filled jejunum from the stomach. It's a technically simple procedure. Unfortunately, there can be complications because of stent misdeployment or an or overlapping bubble loop, and this can result in perforation that will require urgent surgical intervention. The second technique is called the EPAS method that was described by Dr. Itoi, where a lumen-opposing metal stent is placed in a fluid-filled medium between 2 anchoring balloons. This is a safe technique. However, it's not popular because the technology is not available uniformly worldwide, although it's safer. So these are 2 videos that is going to show these techniques. The first is the direct technique, where in this particular patient, one can see a very, very distended stomach. secondary to a luminal cancer, and the patient does have a very adjacent jejunal loop. So methylene blue mixed with contrast and saline is now injected across the luminal obstruction to distend the small bowel. And then once the echondoscope is positioned in the stomach, the small bowel is directly punctured using a cautery enhanced system, first with a 19 gauge needle, and once contrast is aspirated and confirmed, a luminopposing metal stent is then subsequently deployed by application of cautery. The distal flange is first released, followed by the proximal flange within the GI lumen. In the second technique, which is called the EPAS method, that has been described by Dr. Itoy, the echondoscope, the endoscope is first passed, and then a guide wire is advanced across the obstruction into the jejunum. Subsequently, contrast is injected to opacify the small bowel. Once that is done, in this method, the dedicated balloon is advanced over the guide wire into the small bowel. And it's got a double beaded pattern, and this is to illustrate the positions of the two balloons that are now passed over the guide wire. And the balloons are mixed with contrast mixed solution, and they are first inflated to anchor the small bowel. And you can see the balloons, and there is also a good intervening space, and this intervening space is now filled with fluid. The small bowel loop in between the balloon is then punctured using an echondoscope directly using the luminopposing metal stent, with first passage of the distal flange and then the proximal flange is released into the GI lumen. Following this, the balloon is then removed. So this technique is called the EPAS method, and the advantage of that technique is that it anchors the small bowel and minimizes the possibility of misdeployment. There are some caveats with EUS graded gastrojejunostomy. This procedure can be performed only when the luminopposing metal stent deployment area is less than 20 millimeter from the jejunum. And in 25% of the procedures, it may not be possible to deploy the stent. And some Japanese investigators have identified means by which failed procedures can be identified. And this is by performing a contrast study, and the anatomy of the ligament of Treitz gives an indication of the success of the procedure. And they postulate that in patients who have a type 1 anatomy, where the distance is very minimal, like less than 6 millimeters, it's much easier to perform. Whereas in patients where the distance is much higher, like 15 or 20 millimeters, the procedure is likely to be unsuccessful, and these are categorized as patients with type 2 or type 3 anatomy, and this constitutes approximately a third of the patients. So there appears to be a mechanism by which success can be gauged depending on the relationship of the region of the ligament of Treitz on the stomach to the jejunum. Other caveats: one must be familiar with intra-channel deployment of the proximal flange. Generally, some investigators would like to look at the black mark for release of the proximal flange. With this technique, one has to get accustomed to releasing the flange inside the channel so that the procedure can be successfully completed. There also used to be a notion that ascites was a major contraindication, and it looks like the presence of minimal to moderate ascites does not appear to preclude successful completion of the procedure. So in summary, EUSGJ is an effective alternative to enteral stenting and possibly surgical bypass. One development that might accelerate the use of the technology will be the development of dedicated T-tags or other techniques which will improve the safety profile of this procedure. And my last section is going to be EUS-directed transgastric ERCP, or the EDGE procedure, where in patients with Roux-en-Y anatomy, a stent can be placed either gastrogastrostomy or through a jejunal small limb in the remnants at the region of the remnant stomach and into the excluded stomach. So why is EDGE procedure popular? This is outcomes in 178 procedures, and one can see that the procedure is successful in close to 95 to 98% of the patients, and a successful ERCP can be performed in close to 50% of patients during the same procedure. A limitation appears to be the presence of a residual fistula that can be managed at a later time. But however, compared to double balloon assisted ERCP or a laparoscopic procedure, the success rates are quite high. It can be performed in an endoscopy suite with excellent clinical outcomes, and therefore this procedure is becoming increasingly popular. There are 3 steps involved in performance of the EDGE procedure. The most common is the freehand method, where a lams is deployed, followed by anchoring of the lams, particularly if the patient is scheduled for a same session ERCP. In this particular video, we are going to demonstrate the technique. Here you can see a patient with a stomach that is now insufflated by irrigation of water into the excluded stomach from the residual pouch. Following installation of water, a lumino-posing metal stent is successfully deployed with the distal flange in the excluded stomach and the proximal flange via the remnant stomach. This patient is now going to undergo a same session ERCP. The lumen of the lams is then dilated using a balloon, and following dilation, the excluded stomach can be very well visualized. So the stent is now secured by placement of a guide wire, and then using overstitch device, the lumino-posing metal stent is anchored to the remnant stomach. Usually 2 sutures are placed 180 degrees apart, and that will generally give fairly decent anchorage. And once the sutures are successfully placed, using a combination of endoscopy and fluoroscopy techniques, a ERCP can be undertaken by passing a duodenoscope via the lumen of the lams, and once the papilla is reached, requisite ERCP maneuvers can be successfully undertaken. In this particular case, even a cholangioscopy could be performed. And for disclosure, this video was provided to me by Dr. Keshab. There are several caveats to a edge procedure. One, a lumen opposing metal stent can be deployed, can be dislodged during ERCP. So if that happens, your fully covered esophageal self-expandable metal stent can be placed in the gastric remnant with a stent with a self-expandable stent going through the lambs and across the fistula site. And what this will do is it will provide guaranteed access, and it will close it will close the fistulous area. The second will be bleeding. Although Doppler is used, occasionally bleeding can happen, and this can be controlled by tamponading using a balloon, a glue injection, or in very rare cases, if the bleeding is severe, by placement of a fully covered esophageal self-expandable metal stent. A buried lumen opposing metal stent syndrome can occasionally be encountered. Particularly, this happens if the lens was deployed around the region of the gastric antrum. If this happens, then the buried stent can be accessed using a FNA needle and by passing a guide wire through the lumen and coiling it in the remnant stomach, and a second stent is placed within the lumen of the pre-existing stent, and this is the stent-in-stent technique. After a couple of weeks, when the second stent is removed, the first buried stent will come away at time of stent removal. If marginal ulcers are identified, they can be treated with PPI, high dose, and usually this will result in healing of ulcers. Sometimes a persistent fistula can be seen after stent removal, and this usually we remove usually after we remove the stent, we expect all the fistula to close by 8 weeks, and if it persists beyond, we have a problem. This is more commonly seen in patients with associated diabetes mellitus, and more commonly, the longer the stent is allowed to indwell, the higher is the rate of fistula formation. So therefore, lumen opposing metal stents should be removed quickly after the ERCP is completed. Sometimes, to study this anatomy, even an upper GI series may be needed. However, persistent fistulas can be treated by APC, sutures, or by application of overscore clips. Sometimes, despite all these measures, a fistula can remain refractory and will require the use of a cardiac septal occlude device, and there have been some case reports. For patients who require a same session ERCP, the following are important. 1. A 20 mm lumen opposing metal stent should be preferentially be placed. The lumen of the stent can be dilated to 18 mm. They should be firmly anchored. And finally, carefully, the duodenoscope should be passed using a combination of endoscopy and fluoroscopy guidance for successful performance of the procedure. So in summary, EDGE is an effective alternative to double balloon ERCP or laparoscopy assisted surgical techniques in patients with altered Roux-en-Y anatomy. However, in order to completely perform the procedure in a single session, experience with suturing may be required, because it not only increases technical success for same session ERCP, but it also decreases the rates of adverse events. I want to thank Dr. Walk for this opportunity to present in this webinar, and I would like to extend an invitation to all of you to register for Florida Live Endoscopy that will be held from August 18 to 20 next year with live demonstrations performed by international faculty in Orlando, Florida. Thank you.